This presentation is adapted from Sleep Academy, an online CME-accredited course for advanced practitioners and physicians. My name is Dr. Peter Sloan, and I'd like to introduce Dr. Brian Bonner.
I'm going to approach the fundamentals of OSA in the following order. First of all, we'll review the anatomic and physiologic considerations in the disease. Secondly, we'll review the spectrum of the disease. Next, the physiologic consequences. And thereafter, the associated conditions, symptoms, and comorbidities that result from the physiologic consequences. First, some brief anatomic considerations. The pharyngeal airway is divided into 4 regions. The nasopharynx from the nasal entry to the end of the hard palate. The velopharynx, that's defined by the level of the soft palate. The oropharynx, that includes the airway to the base of the tongue. And the hypopharynx, that is distal to this, leading to the level of the vocal cords. The regions that are associated with the most common region of obstruction in OSA are the velopharynx and the oropharynx. The velopharynx associated with the collapse of the soft palate, and the oropharynx because of the tongue. These structures may be enlarged. They may include fatty tissue that leads to the obstruction, or there could be physiologic or neurogenic influences so that the muscle tone in these regions is compromised and can lead to collapse as well. So there can be anatomic as well as physiologic reasons for the collapse. Breathing during sleep is normally handled by the nasal airway. The nasal airway has advantages over the oral airway. The filtration of air delivered to the lung through the nasal airway is more protective than the oral airway, and also there's less resistance to flow than breathing orally. Mild forms of sleep disorder breathing occur with the narrowing in these regions, and this can include the development of snoring, and if the obstruction is more pronounced, there can be a reduction in airflow associated with desaturation or arousal, yet not complete closure of the airway, and this event is known as a hypopnea or hypopnea. With complete obstruction of the oral nasal airway for 10 seconds or more, the event is known as an obstructive apnea. Back in the 1960s, there was a perception that OSA was a rare condition, only occurring in the morbidly obese patient. And over the last 5 decades, we've recognized there's really a spectrum of disease that begins with snoring and then progresses in severity. And with this spectrum, there's a concept that some of the features on the left include symptoms such as snoring, and then this may progress into conditions such as upper airway resistance syndrome and hypopnea. And then moving further to the right to develop disease states, including obstructive sleep apnea and obesity hypoventilation syndrome. These latter 2 conditions having a more direct consequence on health and quality of life. So for those that have reached the far right side of the bar, they usually have progressed through all these stages, maybe as they've gained weight over time. And for those patients who have conditions on the left, they can temporarily exist in a more severe stage. And this be like an example of someone having sedation for an endoscopy. They may have snoring, and then the endoscopist notes that they're having obstructive apnea, and then they're referred to have a sleep evaluation. And sometimes they don't have apnea, but they were moved to the right because of the sedation. This can also occur in using alcohol or chronic sedatives. This concept is also important to understand when clearing the patient for anesthesia. And if the anesthesiologist is aware that the patient has obstructive apnea, they'll take proper precaution in terms of the type of sedation and also extra caution post-op in terms of observing the airway, perhaps delaying the extubation until more awake, and having in a monitored setting for a bit longer perhaps. Conversely, for those patients who have a state of sleep disorder breathing on the right side of the spectrum, treatment ideally will move the condition leftward. And this could include weight loss or other treatments to open up the airway. I'm going to take a closer look at two of these conditions on the spectrum with you next. The most mild form of syndromes in the spectrum is the one known as upper airway resistance syndrome. And at the most severe end of the spectrum is obesity hypoventilation syndrome.
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.